Exciting.
My
It
first live
says,
stream.
okay. Yes. Okay. This is
Fingers
awesome.
crossed.
Hmm. All right. Here we go. Okay. Yes. Okay. This is
Fingers crossed.
all right. All right. Here we go. Okay. It looks like we are live streaming. Okay. Okay. Let me figure out what's going on here. Um, Dr. Edwin.
Hi, good morning.
All right, he is here. I cannot see anything. I see just a black screen. What do you see?
I see yourself. It's live on YouTube.
All right, he is here.
I think we're
I
good.
cannot see anything. I see just a, what do you see?
I see yourself.
Okay, where do you okay. Dr. Barron, I
Yes.
don't see you. Okay, I can hear you, but I don't see you. I'm not sure what's going on. We have a chat here. Show chat.
You may have to.
Do you see
Let's
yourself on the
see.
screen at all?
I do. Yeah. As if we
You
were in
do
a
see.
meeting. So
Okay.
all that's left is to,
Okay. Let me
well,
go ahead.
I think we're good because when I speak, my the focus of the meeting in this live stream uh,
Shows up.
shows my screen, right, which is myself.
Okay. Very good. Okay. Let's go ahead and just start then. We are streaming live. Thank you for joining. Dr. Edwin Barron is joining us. He works with me at Inland Family Community Health Center as a pharmacist. And is it a pharmacologist or pharmacist?
A clinical pharmacist.
Clinical pharmacist.
Correct.
And he's going to talk to us about diabetes medications right now. This is our first time, bear with us, going on together as a live together from Zoom. So, anyways, I'm really excited. We're going to be talking about diabetes medications in a way where it's easy to understand. Um, and yeah, let's go ahead and get started. Dr. Barron, Dr. Edwin Barron. I'll let you introduce yourself and
All
we can
right.
go ahead and get started.
Hi, everyone. Nice to meet everybody. Look forward to educating and providing lots of information. I work with Dr. Legans. I'm a clinical pharmacist, USC trained. I've been from hospital to retail setting to now a clinic setting, ambulatory care. And one of my things that I like to, that brings a lot of pride in myself is educating the public on medications. That's namely why I went into the profession. And really, the basis of it comes down to guidelines, right? What does what is the national standard? What is the gold standard for providing this education on medications, right? Because when people hear diabetes, it could be a scary thing. And one of my things that I do when I'm consulting and providing education to patients is to really bring them towards that discussion and having a one-on-one, so that that way they can get involved in the ailment and understanding the disease state, so that way we can better manage that. So I think that that's what that's what really gets me going each and every day. So yeah, thank you, everyone.
All right. Excellent. Well, I'm truly, truly excited. When let's start from a perspective of, let's say someone is newly diagnosed with diabetes. They're terrified. They don't know what medications. They're afraid they were going to have to be on insulin and give themselves insulin. Can you please kind of talk about, from a perspective of a person, just for maybe a minute or two or three, what medications would be typically used first for someone who has just been discovered to have diabetes?
Sure. So the guidelines have recently changed this year, and so I know it can be scary for most folks starting on, you know, an oral medication or insulin, which is very scary, having to inject something exogenously just to control their blood sugar. And really, what the guidelines say is that this is more of a personalized, independent approach as to what therapies they should start on. And every approach should be individualized to that patient. So typically, what the physician, and this would be something with the physician and the patient, that they would have this discussion, is starting on a medication like metformin, right? So metformin would help and allow the body to become more insulin sensitive, right? So that way they can bring the levels of the sugar back down, and so that way the cells in their body can utilize that sugar. And really, from there, you can start adding other therapies, like for example, Actos, like pioglitazone, for example. It's a different mechanism, different oral drug. Now, like again, like I said, depending on where the patient's at from a blood sugar perspective, meaning an A1C, something that you folks have probably heard of. A1C is a measure of your average glucose in the past 3 months. And it gives
Right.
us an understanding, right, Dr. Ligons, about where they're at and whether or not patients should start on insulin therapy, right? Family history, right? Other comorbidities is just a fancy term we use as far as like, do you have high blood pressure? Um, um, Race also plays a little bit of a factor into it because it involves genetics, and then BMI and other things like obesity and renal disease.
Yes.
So all that has to be taken into account. And one of the other medications, for example, is starting on something like a GLP-1, which is a lot of folks have heard of Ozempic, right? And that sounds exciting. A lot of people have heard about it for weight loss, and it is in the guidelines. It's an injectable medication that essentially allows for the patient to be fuller for a longer period of time.
Okay,
Um,
stop right there.
yeah.
Stop for just a minute. Sorry about that. I just got feedback that they're not able to see this what we're doing. So
Oh,
I am going to have to figure this out. Let's see here. Um, I might have to edit and then put it on that way. Okay. Give me a minute, just a second. Is yeah, I had my husband let me know whether or not he could see it, and he said he cannot see it. So uh connect streaming software to go live, stream setup, will be live control next. Okay, there I think it's trying to do it. Make sure the stream, the one in the string sound next. So, edit the stream metadata. Okay. Okay, next. Start streaming. Start sending this. Okay. Um, so not sure what's going on. At first, at one point, it seemed like we were streaming. Hold on. Download and set up your streaming. I think some things are popping up that I'm not familiar with. So So I'm not quite sure. Like I haven't seen this one before. You know, the stream settings.
Oh, is it another tab for stream
Y-
settings
Yeah,
or pop up?
apparently it says we're live streaming now, so I'm confused. Give me just a second. What an exciting moment, huh? It's an adventurous moment. If you give me just a minute. At one point, I was hearing myself twice. Um, okay. Okay. I do get feedback. Someone is saying I'm able to see both of you. Okay. Well, let's see here. Let us it looks like we're actually connected on we're connected. Let's just keep going. How's that? And then we'll record it. I'm gonna record this now and then I can connect it later if it didn't go through. All
Sounds good.
right. Okay. So here we go. Let's see, where were we? I'm sorry. We were talking about the first one. Typically, I start people on metformin. Okay.
Right.
Um, that's like the first line. What does the American Diabetes Association say about their first line medication?
Right.
Typical.
So what they say with these updated guidelines is that it is available to be used as a first line. Um, Not always, but it really depends on what the risk factors. Most physicians now will prescribe it because they're accustomed to using it. But now, because it's an individualized approach, you can start on a combination of oral medication. So you can start on, for example, Farxiga, right? It's a different class of medications, helps protect kidneys, right? It's renal protective, and so um, metformin is still obviously another option, and based on where they're at in family history, other comorbidities like hypertension or renal disease, we call it CKD for those folks that are not aware of that. But
That's a
um,
kid. What does that stand
that's
for?
it. So CKD is a chronic kidney disease,
Okay.
and so really it's a discussion that it's something that the physician will have with the patient to
Right.
personalize that approach, right? If their A1C, for example, which is an average estimate, right, of their glucose standing in the past 3 months, is higher than what it should be, right, depending on where they're at, um, the physician may decide to prescribe insulin there, right? And so one of the key changes for this year's diabetic guidelines is the consideration of another medication, another injectable, which is very popular and very hot these days. A lot of people are using it
Mm-hmm.
for weight loss,
Mm-hmm.
and it is a GLP-1 receptor agonist, which is Ozempic, semaglutide. So
Yes, very
it
popular,
right, right,
extremely popular.
and so I'm sure, doctor, that this is something that a lot of your patients may ask you for, may inquire about whether or not they more or less qualify for it
Okay, and
in your
that's right.
practice, right? And
Let me
so,
just, it is oftentimes people come in asking about that particular medication. And yeah, it is it is very highly sought after and highly advertised. Many people want to lose weight, and it's a once a week injection, and they are seeing results on it. And so at one point, we were even having a hard time getting that medicine for our patients with diabetes. And for the people with diabetes, it really does help bring their sugars down. We've seen some dramatic changes in it. So, is it a wonder drug? Well, I don't want to say that. Let's talk about that drug a little bit since it is such a popular. Can we talk about some of the ups and downs. The two most popular drugs that I see that we're using for diabetes when first line is metformin and Ozempic. Okay. Those are the
Right.
two that seems like we're using the most. What do you think about that?
Yeah, and metformin's probably the oldest and most popular drug out there because it's been out there for the longest time. It does work. One of the drawbacks about using metformin is that at high doses, typically, and if the patient doesn't take it with food, because it is strongly recommended to take it with food, it can cause diarrhea. Also can cause something called lactic acidosis,
Mm.
which is the buildup essentially of protons in your body, which will translate into the symptoms of like diarrhea, for example, or muscle cramps or abdominal pain. Those are signs and symptoms of lactic acidosis. And usually, when people take it with food, it the side effects are not that so pronounced, but it does happen. And there are other formulations of metformin, for example, an extended release version,
Mhm.
which will uh, mitigate a lot of the diarrhea for a lot of patients. And so it's because it's been out there for the longest time. They are pretty huge pills. I will say that.
Okay.
When I'm dispensing and I'm going about my days of production, they are pretty large. So, you know, I
Yeah, so
do
you see
I,
they're
I do
big, yeah.
understand, yeah, how it can be a little bit problematic for patients, especially the elderly, or the
Hmm.
patients that are special needs, for example, that are
Hmm.
type 2 diabetic. So it's something really that should be, again, personalized approach. And as far as it comes to with Ozempic, it's a different mechanism. It is an injectable drug. A lot of people, and I've had to clear some confusion. They believe that it is insulin, and I think that comes from because insulin is an injectable, and it's probably one of the longest injectables that out there to control your blood sugars. And it is a hormone. It is a hormone. It mimics a hormone, a natural hormone in your body. And so one of the things about injecting Ozempic is one of the side effects, more or less, is that it can cause constipation. Okay, it can cause stomach upset,
Oh.
and
Hmm.
and constipation. So that's one of the things that that a lot of patients tell me is that, hey, look, like it delays your gastric emptying, so it delays the passage of food going through your body and slows it down. So it slows down the appetite, and so
So you're
you're not
talking
eating
about,
as much.
yeah, and you're talking about the you're referring to Ozempic, right?
That's
The
correct.
once a week injection. I
The
just
once
wanted
a
to
week
make sure.
injection, absolutely, yeah.
So that one can cause, I know that it can cause nausea.
So
Um,
with that, because it delays, uh, it's a secondary effect um, of that medication. So it will cause nausea. A lot of people tell me that they have nausea for days, even after
mhm,
injecting it, being placed on the medication. So
mhm.
it's one of the things that I do let people know, and obviously the black box warning for C cell tumors, right? Which is one thing that has been shown in the clinical trials, and so that's what I focus on is educating the patient as to whether uh, as to their understanding of that medication, right? Sometimes they are very excited or very, not so excited to be starting on medication. So my job really is to help make them feel comfortable with that medication, right? And it's about
Right.
like building that relationship, and there are other medications out there. So not everybody's placed on Ozempic, not everybody's placed on insulin. So I know it can be a scary thing for a lot of folks.
Um, when let's talk a little bit about when is a doctor most likely to start talking to a patient about getting on insulin? Let's say now a person has been on medications for their diabetes. Let's say it's metformin. Let's
Mhm.
say there's another medication, and maybe there's two medicines in one pill, like the metformin allogliptin combination, or metformin and Farxiga, or metformin and something else. Because a lot of times we'll start metformin and then we'll start another oral pill medication.
Right.
If we're not doing Ozempic, um, at one point, do you find that, physicians or PAs will put someone on insulin when they have diabetes? When is that typically necessary or highly advised, we should say?
So I would advise, and this is just based on my expertise,
Hmm.
that for physicians to initiate insulin therapy at a A1C level of 10 or more. I would even go as far as to say 9.5 or more. Namely because the AACE, which is the American Academy of Endocrinologists, which is another agency that posts guidelines, they're a little bit more stringent as
Hmm.
far as their glycemic goals, which is where the patient should be from a sugar standpoint. Okay, for those folks out there. And one of the things that I've seen is that it really varies from doctor to doctor based on their expertise, their training. And so for me, I look at it from a pharmacist standpoint. I look at it um, based on numbers, based on the data, right? Based on the A1C, based on family history, based on other comorbidities, where they're at now and where they want to reach. What are their goals, right? And they have to be measurable. And how are we going to get there, right? Set a timeline. 6 months from now, I would like to see you at this A1C, right? And so,
Hmm.
something that I would strongly recommend is for physicians to initiate insulin therapy right around the 9.5 to 10% for the
Okay.
A1C.
Very good. Thank you. That is very helpful. So that's when, when the A1C gets above 8, 8.5, 9, we start to see real bad complications after a while. The vision starts to, if it's up too high for too long, we start having vision problems, and patients start to need to get injections in their eyes or surgery on their eyes. And the other thing is the kidney starts to go through problems. Again, when the sugars are too high for too long, these are some of the complications. Foot problems, not being able to feel things with when you're stepping, and you can step on something and not know it, and then you have a bad ulcer or sore starting in on the foot. And so, can you, now that I start talking about the complications of diabetes, can you talk about briefly about some of the myths that are out there regarding, and some of the fears that people have that are not true, I guess you could say, regarding diabetes, medications and insulin and these kind of things. Some people I have heard over the years, they had it in their head, because of their experiences of what they've heard about insulin, is that once you start on insulin, you can never get off. Once you start on insulin, soon after that, you're going to die. There are many fears that people have that come from what other people say, or what, like I said, family experiences. What are some of the things you've heard, and can you please talk about some of these things?
Right. And so one of the probably the biggest thing I've heard, and it's really a myth, is that am I going to have to inject insulin for the rest of my life? And I've had to educate thousands, if not tens of thousands of patients over the course of my career already on
Mhm.
insulin, on other injectables. And so this disease state can be difficult to manage, but the patient doesn't necessarily have to be on it for the rest of their life. It
Mhm.
really takes two to tango.
Mhm.
The patient, as far as getting involved in their understanding of this in the management of this of their ailment, and the doctor following up with the patient to making these changes um, in consideration with what the patient also needs, right? And so that's one of the things that I talk to a lot about patients, that am I going to have to be injecting insulin for the rest of my life? And that's not
Mhm.
necessarily the case. This disease state can be readily managed. It just takes a lot of education and understanding and making the changes, right? Not so much in the medications, but making the lifestyle habits, right? Are you exercising 150 minutes a day, which is what the American Diabetes Association says, right? 150
150
minutes,
minutes
I
a
mean,
week.
not a day, a week, sorry, a week. And
Hmm.
so that's one of the things that I educate patients on. And also, as far as their diet, right?
Hmm.
Understanding the carbohydrates they eat, what kind of foods that they should avoid, right? Things that will spike up the glucose, like sugary carbs, like for example, like sodas, refined sugars, um,
Hmm.
which you know patients can eat very like sparingly, but it shouldn't be an everyday type of thing. So I spend some time educating patients on what the right foods to eat, and um, different types of uh, foods that will help more or less control the sugar so that we don't get these spikes. For example, switching from white sugar, no, white rice, to brown rice, for example.
Hmm.
And so it's one of the things that I spend some time with patients.
That's good. Yep. High fiber, low carbohydrates. The more fiber, the better, right? The less, processed, the better. The more processed, the worse we are. So,
Right.
processed foods are typically pretty bad. Natural foods are usually much better. White flour, white sugar foods are going to have problems. Too much rice, too much pasta, and too much potatoes are high starchy. And so, yes,
Hmm.
we spend a lot of time talking about foods and so forth. And right now, there's plenty of information on the internet so that you could go on YouTube and put on diabetes diets or diabetes meal plans or cooking with diabetes. There's just so much now.
Right. So one of the things
Okay.
that the American Diabetes Association has put out is the plate method, which
Okay.
really
Hmm.
consists of eating whole, non-starchy vegetables, like for example, like beans that have a lot of fiber but very low carbs,
Hmm.
um, and so really reducing the amount of like refined sugars.
Right.
Um, Kidney beans, chickpeas, pumpkin, sweet potatoes. I mean, they have a whole list. Cantaloupes, uh, dark leafy green vegetables,
Mhm.
um, and so the idea is to reduce the amount of like snacks, cookies, cake, chips, soda, things like
Right.
that.
Right.
At least for a lot of patients that do tend to have large amounts of that, I advise them to kind of like leave that for the weekends or very sparingly, maybe once or twice a week, on a
Hmm.
maximum, and then
Hmm. Right.
yeah, just giving them a list of what fruits and vegetables they should buy. So it's just a
That's-
little changes that count, because
Yeah.
that's what makes a difference a lot, many times, right in the
Makes
kitchen.
amazing difference. Green tea is wonderful. Try to drink green tea. It helps to control the sugars. Cinnamon, put cinnamon like on your oatmeal. If you could switch to steel cut oats, is probably a little better because of the fiber is better. It's supposed to be healthier for you. I think when I do steel cut, it feels like I'm eating healthier. It seems to stay in my stomach longer, and I don't feel as sleepy with regular oatmeal. Regular oatmeal can make you really sleepy, but steel cut oats seems to be healthier, and I think it has more fiber and more nutrition. Anyways, a little bit of cinnamon goes a long way. They even have cinnamon capsules now. The cinnamon is very good for helping control the sugars. Nopales or cactus for um, our people, our Latin community, Latin Americans that like that kind of cuisine. But I've been told and that also helps to control the sugar. So there are certain foods that are, like I said, low glycemic index. Okay, that's a term, low glycemic, and I talk about it in one of the YouTube videos that I've done on diabetes. And anyway, that is very, very good. Like apples, for instance, helps to bring your sugars up, but just a little, and it maintains a healthy sugar level for a few hours. So just things like that is most definitely you'll notice the higher the fiber, the more nutrients and dense the food is, the better it is for the diabetes. But you could certainly look up on American Diabetes Association. They have, I'm sure, a long list. Mayo Clinic, Cleveland Clinic, these type of resources. Up to Date has resources for patients as well, which is really good about foods that are good for diabetes and foods to avoid. But you know what? I've seen people go to almost the extremes to save themselves and to get with that determination that people have. I don't want to be on medications. I don't want to be on insulin. And they make those hard core decisions to nope, I'm staying off of all those processed foods. I'm doing, juicing. I'm doing a lot of raw fruits and vegetables, water. That's primarily what I'm doing. They're making intentional decisions and staying off of excess amounts of fried foods and so forth and so on. And I have seen them drop their A1C. I've seen their kidneys improve. I've seen the blood pressure improve, the cholesterol improve, their weight, their energy levels just soar, and now they're able to exercise and enjoy life better. Have you seen such remarkable changes in your career?
I have. I have, and I'm proud to say that I've actually helped patients bring down their A1C substantially by at least 3, 4 points, maybe four and a half,
Wow.
in less than 6 months.
Wow.
And it takes two to tango, and it takes a very extensive understanding of the disease state and what they should be eating,
Mhm.
and really also having that support, right, having that support in your family about making these changes, because sometimes, yeah, you do have to kind of consider uh, spending a little bit more to make these changes, and not everybody can afford making these changes, but it really starts with just the simple basic small things, and little by little you start compounding, and you can see these changes. But I've seen it before when I used to work with patients here in the LA area, and
Mhm.
so and I hope to see the same here and at where we're at. And so that's one of the things that brings pride, is that you can make these changes. It just starts with the education, because us as
Mhm.
providers, Dr. Legon says,
Mhm.
we have the ability to educate the patients, and that's really what we're in for, and
Mhm.
um, you know,
Yeah.
again, like, going back to my roots, like, that's how I started in this profession, and so it's one of the things that I take very seriously.
Yeah. You know what? I am with that, we're going to go ahead and get ready to conclude. I'm going to see if there's any comments or anything, if I can, but I am just so grateful for you coming on today and helping people to understand that not necessarily do you have to, once get started on insulin, do you have to stay on insulin? You can, like you said, I like that term. It does take two to tango. It does take and I like to say it takes a village because
Absolutely.
it takes the pharmacist helping to break down and understand. If the doctor that you see doesn't explain the medications or doesn't explain some of the fears you have, a lot of times the pharmacist they can help you. Like Dr. Barron will actually take some time to help you understand your questions and understand the medications and
Absolutely.
understand what you can do. You have some power and control. over this disease state and many other disease states for that matter. Um, any other comments at this time, Dr. Edwin, Dr.
Well,
Barron?
I want to thank you for inviting me to talk about the medications and a little bit about what the guidelines say, right? Because I think that that's something very important. Um,
Yeah.
it is the gold standard, right? As how we go as far as treating this disease state. And
Oh,
yeah, so I want to thank you, Dr. Legons, for inviting me out here. And for
thank you.
any people out there that, patients that are interested in learning more, we can definitely put out more information. I think that there's still
Yeah,
a long way to go. And it
yeah,
just starts again, like little by little. And
that's right. Right. I think there is a lot more medications. We did not really touch on that only because I wanted to just get things started, and maybe if you don't mind you could come on again because I'm sure there is going to be some more questions that come up and people want to know more.
Absolutely. Yeah, most definitely. Yeah, I'd be honored to, and it'd be a pleasure. Thank you.
Yeah, I appreciate it. I thank God for you and I thank God for our audience. And you know what? I'm thankful to God also for the medications. And some of these medications, like you said, they've been around a long time and they're pretty helpful to people and as they pursue lifestyle changes. And sometimes the medicines play a big role as long as with their lifestyle changes as well. So I'm grateful for these things. But we will say goodbye for now, and we will have more conversations in the future. Also, would you mind maybe coming on, Dr. Barron, for talking about high blood pressure medications one day?
Absolutely. Hey,
Yeah,
I'm your clinical pharmacist, so I'd be more than happy to. That's really what I went to school for. So
yeah,
yeah,
we'd love,
absolutely.
we
It'd
love it.
be a pleasure.
We'd love to do that. Okay, we'll talk more, and we'll thank everybody. Thank you so much for coming on, and have a great day. God
Bye
bless.
everyone. Bye.
Peace. All right. Bye-bye. Okay. All right. And let me go ahead and hold on just a second. Let me figure out how to stop the live recording. I don't even know if I started it all the way. So, okay. Okay.